So emergency medicine is, I did internal medicine first, went back and did a second residency in emergency medicine because it became very clear to me about halfway through my second year of my internal medicine residency that wasn't for me. I needed something more immediate. I needed something where I had an impact right now, and I needed to connect with people really fast. I liked that. I liked thinking on my feet. I liked having to make decisions with not complete information and being good at adjusting it when new information came in. That's what you do. That's what you do. Most of us love the detectives. Most of us love the jazz, the adrenal sort of squeeze that goes with this. So this is what we do, and my sort of approach to emergency medicine now is I adore this. I love to go in and think on my feet. And when you do that, when you think on your feet, when you realize that you're kind of taking bits and pieces of information and adjusting all the time, you realize that really nothing is more important than the vital signs. And we kind of like diss them, honestly. They're just these numbers that get thrown up on our EHRs that keep getting populated and populated as they get rechecked and rechecked or whatever. And often we don't really pay super close attention. But I will tell you, the vital signs are called vital for a reason. Vita means life. They're the life signs, and they are. So this is the respiratory rate, the heart rate, the blood pressure. This is your temperature, and actually, honestly, it's probably these days, especially we're so focused on it, is your pulse ox. How well are things getting transmitted into your system? These things are really crucial, and one of the things that I've learned, having done this now for over 30 years, is the vital signs will come back and bite you in the backside if you don't pay attention. If you just gloss it over, that respiratory rate of 22, that one blood pressure that was a little bit low must have been an error, that's going to come back and bite you in the backside. So let's talk about the vital signs and how to be astute clinicians in interpreting what these codes are telling you, these 5 core numbers that tell you a tremendous amount about that person in front of you. The other thing I want to mention, and this kind of tags onto Rick's talk he just did, is that please look at your chart. One of the things is always before discharge, make it and I'll tell you, the reason I do this now is I got really burned once by not doing this, is look at the chart before you discharge and look at all those vital signs. Because sometimes one will have wormed its way in there where the nurse stopped by and got another blood pressure and just happened to document that one time the systolic was 60 and you didn't pay attention to that. The time I got burned on that was a guy who was lying on his back, had been a sort of a trauma patient from a kind of weird trauma. He'd been picked up and kind of thrown against a chain link fence. Just held up there, not really assaulted at all, but had been thrown up against a chain link fence, and one of those little pokey out ends of the chain link had poked him in the back. So he came in as a puncture wound, basically, to the back. He looked fine, his vitals were fine, his x-rays were fine, everything was fine. He didn't have a pneumo. We kind of just sat there and watched him for a while. We got busy, which turned out to be a good thing. Because as he laid there, he just laid there just fine, sat up to go to the bathroom, felt a little dizzy. The nurse checked his blood pressure dropped to 60. He laid down, it was back to normal. Well, beautiful, great. I didn't notice that 60 until he stood up again, was walking out the door, and damn near passed out walking out the door. Well, it turns out that little pokey end of the chain link fence had gotten a vessel that had leaked slowly over time, and he had a big hemothorax. He didn't have it initially, he had it later. That one vital sign was my sign. He would have probably passed out in the parking lot. That probably would have been a big clue that I missed something. But it made me realize that I need to go pay attention to all those things. Don't blow it off to it must have been a mistake. Don't blow it off to the field blood pressure. They don't know what they're doing out in the field. They do, they know very much what they're doing. So these vital signs are really key. The other pet peeve I have is the term vital signs stable. The most stable vital signs in the world are death. Right? 0, 0, 0, 0, 0. They're the most stable vital signs we have. What you're better off writing in the chart is vital signs normal. That means that you looked at them, makes you look at them, and interpreted them. So you've actually paid attention. Be careful with the term vital signs stable. A hypotensive patient who stays septic for your whole shift is stable. They're just stable sick. So pay attention. All right, let's start with the first vital sign, the temperature. And we know that the temperature, and I'm going to spend time on measuring things too, because we make mistakes sometimes on our vital sign measurements because we make an error from that. So vital signs, that when you're checking a temperature, we know that there are lots of ways to do this. And an elevated temperature is anywhere between 100.4 and 100.6, depending on the source. But around 100.5 is considered an elevated temperature. Now, we usually take a temperature orally, right? We usually just stick that thing in their mouth and it beeps off a number and it gives you a number. But you can change your temperature right now. Suck on a piece of ice. Drink a super hot cup of coffee and take your temperature right away. You can change your temperature now. We know oral vital signs are not reliable, often not reliable. Honestly, if I don't really care what somebody's blood pressure or what temperature is, I'll check an oral, that's fine. I'll check an armpit for that matter, if I don't really care. But if I really care, I need to get like a rectal temperature. And you know this, right? You've all had the situation. The vital signs are normal, you've checked the chart before you walk in the room, you put your hand on the patient, it's like, oh, wow. That person is febrile, that person is hot. There's no question they're hot, but the temperature is normal. Trust yourself, don't trust that number. If your hands say this person is hot, that person is hot. Get a core temperature, and the best core we can get is a rectal. You don't have to do all the fancy schmancy esophageal, whatever. Those are in specific situations. But in general, just get a rectal temp. It's a pain, whatever, but it is really more accurate. And if you really want to know, check a rectal temp. Axillary temperatures, I don't really care what somebody's armpit temperature is, do you? I don't care what their armpit temperature is. It's not reliable. It's absolutely not reliable, the armpit temperature. Tympanic temperature membranes, I get a really good temperature of the cerumen impaction in there, but I don't really necessarily get a good temperature of the person. And it depends on how convoluted their ear canals are, et cetera. If you really care, it's a rectal temp. If you really want to be accurate, it's a rectal temp that you need. And we know that most elevated temperatures, when it comes back high, are usually caused by an infection. And that's what you go to. But I want to add, I'm a big sort of easy mnemonic fan. I like sort of things that I can do a quick check that make sure I don't miss things out in the fringe that could hurt somebody. So when I see a temperature is elevated, I think of a mnemonic that I call time, so that I don't just stick on the I, which is infection. I remember temperature, okay? I remember, or toxic. I remember things like serotonin syndrome, neuroleptic malignant syndrome. So toxics in there. Metabolic, I remember thyroid disease. If I don't remember that, if I don't see that elevated temperature and remember my time mnemonic, I may forget that thyroid disease causes an elevated temperature. Oh, by the way, back in toxic, salicylates are there too. And then E, right now we are living in a globally heating up planet. Environmental is absolutely a cause of elevated temperature. It's what 100 people died of in the Pacific Northwest recently, is basically heat stroke. So remember, if a temperature comes back elevated, it's a good temperature. You ask for the rectal if you really care. If it's elevated, remember the mnemonic time. Toxic causes, infection, of course, metabolic, remember thyroid, and environmental. Don't forget that heat stroke is a cause of elevated temperature. Now, to treat fever, we all know how to do this. You all know how to do this. We actually, when we talk about pediatric sort of infections, we'll get into this more in depth, but you know what the doses are, you know what the medications are, whether you add them together or not is kind of, honestly, is more a style point than a substantive point. They're both equally effective in bringing down temperature. So acetaminophen, ibuprofen, in fact, all the nonsteroidals, all fine at bringing down temperatures. Just check the dosing so you're accurate on this, but we're all good at that. We all are pretty careful about that. Now, your blood pressure. I'm going to spend a whole talk on hypertension. We're going to talk about hypertension specifically. But a couple things to know about blood pressure. The guidelines about your blood pressure change on a regular basis. And what you're going to hear from me later in the course is the up-to-date version of this, the latest and greatest version of what we do with elevated blood pressures. But a couple things to know about in the emergency department. We know that a thing called white coat hypertension is real. We know that. Anxiety increases your blood pressure. We know that that is real. So if somebody's initial blood pressure is elevated, there's a thing called regression to the mean. Whereas they kind of hang out there for a length of time, things kind of settle down, they get all distracted by the crazy person screaming over the other side of the ER, and their blood pressure comes down. Check it again to make sure it really is elevated. That's what they do in offices. You're not considered hypertensive on a single measurement in anybody's office. It has to be 3 measurements over time. So don't peg it as hypertension on a single measurement. If the patient, though, does through the whole ED stay have their temperature or their blood pressure elevated a little bit, not the super high ones, we'll talk about those later, but elevated, it's like, okay, yeah, technically that's elevated blood pressure. Write that down. Elevated blood pressure, and refer them. And again, we'll talk about that in detail when we talk about hypertension together later. We make mistakes in measuring blood pressures. We do it all the time. Now, a couple things. I'm like an ultra nerd. My husband, he's an ER doc as well, and he's like, oh my God, you are such a nerd. I bought a blood pressure cuff recently because I was kind of curious about our blood pressures. And I bought it, which you never do, by the way. Don't get a blood pressure cuff. You end up taking it way too often. It's just silly. But what I did is I checked out some of these sources of error. So I basically laid down and checked my blood pressure. And then I stood up and checked my blood pressure, and it changes depending on your position. An accurate blood pressure is meant to be done with the patient sitting with their arms supported, I'm out of the box here, at the level of the heart. That's how it's meant to be done. So think about how we do it in the emergency department. They're lying down, they're standing up, we move them around, we lie them down, we do all kinds of sources of error. So remember, accurately should be level of the heart that the patient's sitting. Hanging down can raise your blood pressure, lifting it up can decrease your blood pressure. So just know that that's one source of error, but that's not the biggest source of error. You all could guess the biggest source of error that we make in the ER as far as blood pressure is concerned. That's the cuff size. And you know how you know that? You can hear it. Right? So somebody pushes the button, walks away from the bed, and you hear this, it's going up, it's going up, it's going up. It's like, because they have a thigh cuff on the teeny tiny little lady's arm. It's going to take forever to blow that thing up. It's like trying to blow up a floaty in your pool. It's just not going to blow. It's going to take a long time. The other thing is we also can hear the one where it starts to blow up, and then you hear the Velcro go, and it pops off. Right? Those are the wrong size cuff. If the cuff is too small for the person's arm, the blood pressure is going to be falsely elevated. If the cuff is too large for the person's arm, the blood pressure is going to be falsely low. And we make that mistake all the time. There are all kinds of things on this slide if you're interested to get the exact right measurement, but it's actually pretty easy. And if you look, you can usually tell. But there are ways to do this. There are cuff sizes. Use the correct one to get the right blood pressure. And this is particularly important to people who might be septic. So you really want to know, have they hit that threshold number where I'm really worried about their blood pressure? So it's more important, honestly, on the low side than the high side. But make sure you use the right size blood pressure cuff. Now, a couple other things. We often will attribute somebody who has an elevated blood pressure to pain or anxiety or stress. The reality is, if somebody's blood pressure stays up through their whole ER stay, it's probably really elevated blood pressure. They may actually even be truly hypertensive. So don't blow it off to that. Really pay attention to the vital sign itself. If you end up backing into, yeah, it must have been because they were stressed out or sad or in pain, now they're better, that's all cool. But don't blow it off up front to that. The other thing is a headache. An elevated, so I'm just going to give you some odds. We're in Vegas, let's play the odds. Say somebody comes into the emergency department with a headache. Well, we have 100 million visits to medical care for headaches in the United States per year. Say somebody comes to the emergency department and they have an elevated blood pressure. Well, we have 1/4 to 1/3 of the population, perhaps even more, who have hypertension in this country. Those two Venn diagrams, when you overlap them, there are going to be a whole lot of people with headaches and a whole lot of people with elevated blood pressure, and the two don't necessarily go together at all. Address each separately. Address elevated blood pressure as one separate complaint, address a headache as another. If you fall into the pitfall of it's a headache and their blood pressure's up, that headache must be from the blood pressure, you're going to end up missing a serious cause of headache at some point in your career. So just address the two things separately. Don't attribute symptoms to elevated blood pressure. And then again, don't treat it just because the number is up. Don't do that. One of the things we found a long time ago, which was very clear, is the idea of making somebody's blood pressure normal in the ER when they're not normal at home and they've been that way for, years. Trying to just drop them to a normal blood pressure number in the emergency department can do more harm than good. You think about what we do when we treat blood pressure. We don't say we want your blood pressure normal in 5 minutes. We say, let's get you off the salt, let's get you exercising, let's have you lose that 25 pounds. I'm going to give you a low dose of some sort of antihypertensive, and we'll bring it down over time. Don't make a number normal just to make a number normal. Okay, if you have a reason to treat the blood pressure, that's one thing, and we'll talk about those reasons in the other talk. But don't just make the number normal. Just note in the chart elevated blood pressure and send them on their way. Okay, don't treat it to make it normal. Now, we worry about blood pressure that's low, not just high. We worry about blood pressure that's low, and we tend to think of shock as a low blood pressure state. But it turns out that shock is just a low oxygen delivery state. It's basically, and one of the ways that the oxygen doesn't get to your cells is because your blood pressure is low. That's one version of shock. But you could be profoundly anemic with a normal blood pressure and actually have your end organs not get enough oxygen. The key here is basically oxygen supply to the cells. So shock is, and this brings up this idea of what's compensated and uncompensated shock. We see this in kids, right? So kids may actually be in shock, but their vital signs look pretty normal, but they start to get that little bit of cyanotic look, that little bit of mottled look. Their mental status isn't quite right, but their vitals are still fine. They're still compensating here. Their heart rate starts to go up, they're still compensating here. We have two different kinds of shock, compensated and uncompensated. The bottom line for both is that not enough oxygen is getting to the cells that need it. We know, and we've known this now for a while since we've gotten really good at sepsis and we've gotten good in our recent sort of really sick people we've been taking care of, is that high lactic acid levels tell us that there's not enough oxygen getting to those cells. So shock isn't a number. Shock is a metabolic state. It's a metabolic state, and it helps you kind of think about how you look at, somebody can be in shock with a normal blood pressure about a heart rate of 150 because they're trying their best to get the oxygen out to those cells. So just know that shock, although the number low should alarm you, people can still be not perfusing very well and have normal blood pressure. So that's kind of key. There's a thing called the shock index. It's on this slide for you. That's what's used in all the research, the sepsis research, is this idea of the heart rate divided by the blood pressure. And I kind of use this as a ballpark. If that range is basically, it should be less than 0.9. Think about your blood pressure. Your heart rate should be 60 right now. Your blood pressure should be 120/80. We'll just pick that. So if your systolic blood pressure is 120, and I basically divide my heart rate by my systolic blood pressure, I basically have a shock index of really low. My shock index is 0.6, 0.5. If I end up, though, where I'm really tachycardic and my blood pressure is low, now I end up with a shock index of 1, 1.5, even 2. Now I get it. I understand why that high heart rate, even with a normal blood pressure, can still be shock. So it's kind of a concept I think is important. It helps you be a better clinician, and that's the whole goal of this course for y'all. Now remember, a couple other things. I can literally walk around this room and decide I'm just gonna, slice open your carotid for fun and bleed you out 30% of your blood volume before we stop that bleeding. Depending on your baseline state, if you're a baseline really healthy person, you may have your blood pressure could stay completely normal by even losing 30% of your blood volume. Your heart rate may actually not even change. We'll talk about orthostatics in a second. So know that there's a lot, people's physiology and their sort of buffer of how much stress they can handle physiologically is very different. We know older people, it's a little bit of a problem, and actually older people can be on meds that make it a problem, right? They can be on a beta blocker where they never get tachycardic. So be smart in all of this. Know that the blood pressure may be normal even if they have a blood loss. We know that people may not get tachycardic even if they're in shock. Again, beta blockers, maybe you're super healthy. Your resting heart rate is 40. Now you get shot in the stomach and you're bleeding. You may not really bump your heart rate until you really have a lot of blood volume loss. So know that these things, again, it's a nuanced practitioner. You guys are being super smart interpreting those vital signs. You're being super careful in interpreting those vital signs. And we do know that some people, when they get super, super shocky, will drop their heart rate. And we know that that's actually usually a pre-morbid finding. If they've gotten to the point where their heart is like, that's it, I'm done. I can't do this anymore. I am tired. I'm just going to brady out. We know that that's a problem. So people who are in profound shock and they get bradycardic, that's actually usually a bad issue. Now, heart rate. A couple things about heart rate. Rick talked to you about how to greet a patient. These days we're doing sort of touchless greeting, which is really sad. You don't have to do touchless anything. Keep your gloves on. You can touch anybody. And the reality is when you greet someone, I think a really good technique that gets the allowed touch in there, sort of the acceptable touch in there, and gives me a lot of medical information and lets me introduce myself, is I like to go into the room, say, hi, Mr. Gonzalez, I'm Dr. Birnbaumer, I'm your doctor today. I shake their hand, I put my fingers on their radial artery, and I feel. That gives me a couple things. Now, if gloves on, I can't tell if their skin is moist, but I can usually tell if it's cold. I can feel that pulse. And what I really want to know about that pulse is not just the number. I can look at the monitor and see that. I want to be smarter than that. I want to know, is it strong? Is it thready? Is it regular? Is it not? I don't need that monitor to tell me if somebody's hypotensive. If I put my hand on somebody's radial artery and I don't feel it, and they're looking a little iffy, I feel the pulse in their groin after I tell them why I'm doing that, and the pulse is there, I know they're hypotensive. Systolic of 90 is what I feel here. Systolic of 60 is what I feel here. Oh, I have somebody who's hypotensive. I can tell that without a number. I don't need a blood pressure cuff. I can use my smarts and my hands to tell me that. So do this. Feel for the pulse. If the pulse isn't there, feel somewhere where it should be. This is 60. So it's 90, 60, 40. Okay, 90 at the wrist, 60 at the groin, 40 at the neck. If that's not there, then I know somebody's got in shock. And if they have it one place or another, I have a range of blood pressure where it might be. So what's the strength? Is it regular or irregular? Is it fast or slow? I don't need to count it. I can tell. You can tell. Your fingers are smart. We know that a, quote, normal heart rate for adults is between 60 and 100. And to be honest, it's more like 60 to 90. Getting over 90 starts to get, in more normal healthy people, that starts to get in a range of, I'm going to pay attention to that. And make sure if there's anything about that that feels funny to you, their heart rate's irregular, they're missing some beats, what is happening here, it's kind of thready, get them on a monitor. That's your brains, much better than a machine. Your brain's telling you that person is sick. So again, vital signs are vital. They are the signs of life. You're using your smarts to get there. Now, the vital sign that doesn't get any respect is the respiratory rate. And in every chart across the country, it is 20. It's just ridiculous. Actually, it used to be 20 for sure, because all we used to do is count for basically 15 seconds and multiply times 4. Often you had 5 breaths in the first 15 seconds, multiply times 4, and there we go. We've got 20, and that's what got written in the chart. We're more accurate now. You can actually watch those monitors and see, or God forbid, use your eyeballs and watch them. If you're going to really watch a respiratory rate, you need to watch for more than just 15 seconds. You really are better off watching for 30 or even 60 seconds, especially people who end up with periodic kind of breathing problems. And when you're doing that, when you watch, use your eyes, use all these senses, because when you're watching somebody's breathing, and you're don't just count, really watch. It's like, wow, those are gigantic breaths. There's only 10 of them, but wow, those are so deep. Well, maybe that person has DKA, and that's Kussmaul. You saw it. You watched it. You paid attention. Are they working hard to breathe? The rate is normal, but man, they've got those intercostal retractions. They've got supraclavicular retractions. You paid attention. See how hard it is that they're working to breathe. So paying attention to all these clues, you're getting so much information from what are just the boring vital signs. The other thing is watch respiratory rate trends. So I'm going to give you an example of a case. We had a case over in our psych ER. So that's your sort of venue. The patient came in with a respiratory rate that was normal at 12, normal counted at 12, and over the course of over 24 hours, it went 12, 14, 16, 20, 22, 26, 30, and we got called at 32. What toxin did that patient ingest? Oh, I heard it. Salicylates. That was watching the respiratory rate increase in somebody who initially had a respiratory alkalosis, eventually had a metabolic acidosis, and got to us sick as a dog. The only vital sign clue to that was that respiratory rate. Somebody paying attention finally said, wow, this person's not just crazy, this person is sick. So watch that. Watch those vital signs. It really, really helps you. They can be respiratory distress with normal vital signs. Pay attention. Now, one of the things I want to focus on here, and it's one of the last things I'm going to focus on, is orthostatic vital signs. When you practice long enough, you realize that orthostatic vital signs are one hunk of hooey. They are just really, so I'll tell you why. I'll tell you a couple reasons why. If I were to do orthostatic vital signs right now in this room on all of you, we're going to put cots all around the room. We're going to let you chill laying flat for 5 minutes. I'm going to take your blood pressure. I'm going to sit you up and I'm going to follow all the rules. I'm going to sit you up and let you sit there for 2 or 3 minutes and settle in and then do it again. And then I'm going to stand you up and let you chill for a little while and then do it again. About 10 to 15% of you are going to have abnormal vital signs. Now, I'm going to take separately from the fact you all might have been up drinking and having a party last night. That's separate. This is just you as a baseline human being. So orthostatic vital signs can be abnormal in normal people with normal volume status. So that's one problem with these. Older people, where your autonomic nervous system becomes less efficient, it just becomes less good, you can be orthostatic and still be fine. You may never become orthostatic and still not be fine. So that turns out that's a problem. They're very, very misleading. The bottom line, and I'll tell you, so those of us in this room, our secret is we will do them when requested for all the services that want them, right? OB always wants it. If there's maybe a GI bleed, they always want it. There are certain groups that always want orthostatic vital signs, but you are going to be smarter, and you are going to know that even if they're normal, it doesn't mean the person's normal. And even if they're abnormal, it doesn't mean the person's abnormal. I'll tell you what is abnormal. And you've all seen this. So you order orthostatic vital signs. Good for you. You ordered it. They were asked to order it by whatever service. You order orthostatic vital signs. You walk away. You watch, this happened recently. We have medical students that do nursing shifts where I work, and God bless this young medical student was over there doing the orthostatic vital signs, looking at his book and all the rules and how long to stand, et cetera, and the patient is doing this. That's positive orthostatic vital signs. okay? I don't need a number. The person's going out. So symptoms. I stand up and I get really dizzy. I'm done. I'm finished. I stand up and I think I'm going to pass out. I'm done. I'm finished. That's positive orthostatic vital signs. If I need numbers, fine, I'll go get them, but the symptoms are really what trump everything. And if you try to find literature on this that is the be-all, end-all, sort of, this is the landmark paper that tells you exactly how to do it and what's the abnormal stuff, there isn't one because there isn't one. So there are all different kinds of ways of how we should measure this, how long they should be in what position, how long they should, whatever. We have all kinds of numbers that people will pick. Well, the heart rate needs to go up by this amount, or the diastolic needs to go down by this amount, or the systolic needs to, and it's all over the place. So just know that there is no consistent agreement on how to do them, no consistent agreement on what's abnormal, and the only thing I think we can consistently agree upon is symptoms count. Symptoms count. So go ahead and do them for the people that want them. If that ends up changing their mind on what needs to be, needs to be done, have a little talk, and we'll chat about it. But know that orthostatic vital signs are a real problem, Again, this positive thing, I'll give you an example of this, just to give you a really, so I was when I was a medical, or an EM resident at Harbor, this is like 1,000 years ago, before a lot of you were born, they did a study on us as volunteers. We were volunteers, kinda, and what they did is they bled us. So my class, there were 13 of us, they bled us. They bled us up to 20% of our blood volume. We basically donated blood up to 20% of our blood volume, and I think it was 30% of our blood volume, and they looked at what happened to us. So young, healthy 20-somethings, what happened to our vital signs? About a third didn't change at all. A third of our blood volume and didn't change at all. About a third either got hypotensive or tachycardic, and about a third got both hypotensive and bradycardic. I mean, it's like, what is this? What do you do with that? I have no idea. We have no idea what this means. Absolutely zero. In young, healthy people, we have no idea. So symptoms trump everything. Now, the last vital sign is the pulse ox. And honestly, if you've been practicing over the last year and a half, you have become a true expert at pulse oximetry. It has been a true, honest to God, fifth vital sign over this whole pandemic. It's been a really crucial vital sign for us to follow. The number that you really care about on that pulse ox is 90. The reason you care about 90 is a pulse ox of 90 correlates with a PaO2 of 60. So it's just, there's my little chart there, it correlates. And that is the slippery slope below which every 1% drop in your pulse ox is a lot more impact on that PaO2. It really drops quickly. But up above that, that's the reason, by the way, when we give oxygen to people, we basically get them up to an O2 sat of sort of 92%, and we're good to go there, because look at that plateau. They got a lot of wiggle room there in that plateau. I'm kind of good to go up here in that plateau. But as soon as I hit that 90 and I start to drop, I know that what's happening in that person's body is their oxygen supply is dropping precipitously. So pay attention to that fifth vital sign. Pulse oximetry has changed everything we do. We used to have to do blood gases back in the day. I didn't have pulse oxes when we started. It is a godsend, an absolute godsend. Assume a low pulse ox is real. And if nothing taught us this, COVID did. First patient I saw with COVID came in chatting, playing on her phone with an O2 sat of 70. I thought it was wrong. It wasn't wrong. She just had COVID, and we're back in the day of like, what the hell is this infection? So just trust it. It's real. Okay, the pulse ox it has its nuances. There's certain colors of skin, darker color skin can make it a little less reliable. Definitely dark fingernail polish can. But just know that pulse ox is a truly fifth vital sign. And then the last thing I want to mention before I pass this off to Jan is pediatric dosing. Vital signs, etc., pediatric vitals. So all of you with kids know that children are born, any child out of the uterus should have a systolic blood pressure of 70 or higher. Okay, so they should, that's like your from there on out. But their respiratory, it's a normal respiratory rate of 60 in a newborn, 60. Wow. Just don't memorize any of it. Go to those apps that Martha was talking about. Find an app that gives you normal pediatric vital signs. I have one that's starred on my phone, so I just can go. It's like, okay, how old is this kid? Oh, this is fine. I don't have to worry. So just know, and your Breslow tape has it. Know that they change really fast. It's not something that's maybe different from 1 month to the next as the kid gets older. So just for pediatric stuff, use something like a Breslow tape. Use something like an app that will help you. Again, there are charts like this. This came in a book that I bought. There was a little chart thing that came out. Just know that there are ranges of normal for kids, but they really are way different than adults. So those vital signs are vital. They're fun. Go interpret them. Be smart when you do that. And I'm going to pass off to Jan. Come on up.